A single laboratory result changed the trajectory of the entire investigation, revealing tracheal wall thickening as a central finding in the autopsy report. The cause of death was initially listed as drowning. However, the medical examiner disagreed upon further examination. Initial reports indicated submersion and pulmonary edema consistent with near-drowning events. Yet no definitive evidence of water inhalation or aspiration could be found. Microscopic analysis revealed marked inflammation within the larynx indicative of laryngeal edema. This finding suggested an obstructive mechanism rather than a direct cause related to fluid ingestion. The thickened trachea walls were consistent with reactive changes secondary to severe airway obstruction, pointing towards a different causative agent for asphyxiation. Further toxicological analysis was ordered to explore potential contributors to the laryngeal swelling and resultant respiratory compromise. Chapter: Case background. The incident under examination occurred on March 15th in a suburban residence located in Springfield, Illinois. The initial report was made by the tenant of the apartment, who arrived home after an extended period away to find the apartment door slightly ajar and an unusual silence within. Upon entry, the individual noted that the deceased was lying supine on the bedroom floor, with a notable lack of responsiveness. Initially, it was assumed that the deceased had fallen asleep in an awkward position or had experienced sudden illness, prompting immediate contact with emergency services. Emergency responders arrived shortly after to assess the situation and found no signs of external trauma or struggle, further complicating initial assumptions regarding the cause of death. The absence of any apparent injury and the state of undisturbed belongings within the apartment led to a suspicion that respiratory distress could have been involved in the fatal sequence of events. Chapter: Initial findings. First responders encountered an adult male positioned in a supine posture within his residential bedroom, unresponsive and without evidence of spontaneous respiration upon arrival. The scene exhibited no signs of forced entry or foul play, with environmental conditions consistent with normal indoor habitation, including ambient temperature and humidity levels. No external injuries were visibly apparent on the exterior of the body, suggesting absence of traumatic mechanisms for death. Initial medical assessment indicated compromised airway patency. Auscultation revealed diminished breath sounds bilaterally, but no adventitious noises such as wheezes or stridor. The first responders' observations noted a cyanotic appearance and dilated pupils with sluggish light reflexes. Given the lack of obvious injury and presence of respiratory distress signs, the initial manner of death was classified as undetermined pending further forensic investigation. This classification prompted an immediate request for emergency medical services and subsequent referral to the medical examiner's office for autopsy and toxicology examinations. Chapter: Forensic investigation. At the examination site, multiple airway devices were identified near the deceased, including a tracheal tube and an endotracheal mask with visible signs of use. Swab samples from the mouth and throat exhibited particulate matter indicative of allergens or irritants consistent with laryngeal edema causation. Notably absent was any evidence of physical trauma to the neck that might suggest strangulation or constriction. A sealed container containing respiratory secretions collected post-mortem was placed in a secure bag for toxicological analysis, adhering strictly to chain-of-custody protocols. The presence of thickened tracheal walls observed during the autopsy corroborated findings from the scene investigation, indicating significant airway compromise consistent with laryngeal edema leading to asphyxial death. Microscopic examination of the deceased revealed significant tracheal wall thickening and laryngeal edema. Histopathological analysis included hematoxylin and eosin staining to assess cellular infiltration and tissue integrity. Immunohistochemistry was conducted to detect cytokines indicative of inflammatory response. Serum samples were analyzed for allergen-specific IgE levels, revealing elevated concentrations consistent with anaphylactic reaction. Tissue specimens from the trachea demonstrated marked edema and submucosal vasodilation. Electron microscopy confirmed disruption of epithelial cell junctions and increased intercellular spaces. These findings support a diagnosis of acute laryngeal edema leading to airway obstruction, consistent with anaphylactic asphyxia. The examination revealed significant thickening of the tracheal wall indicative of laryngeal edema as a primary cause of death due to airway obstruction. Microscopic analysis confirmed the presence of acute inflammatory cells consistent with an allergic reaction or rapid onset irritation, suggesting a sudden event preceding death. Based on the degree of edema and pulmonary congestion, the postmortem interval was estimated between 6 to 12 hours prior to discovery, consistent with the last known sighting reported by witnesses. Forensic evidence, including pollen analysis from nasal passages and allergen testing, provided corroborative data supporting an allergic trigger. The timeline established that exposure occurred approximately 2 hours before death, aligning with witness statements on timing of symptoms onset. This sequence contradicted initial hypotheses of accidental suffocation or intentional strangulation, focusing forensic efforts on identifying potential environmental triggers, such as pollen influx or sudden allergen release, in the immediate environment of the deceased. The timeline established that exposure occurred approximately 2 hours before death, aligning with witness statements on timing of symptoms onset. The presence of laryngeal edema and tracheal wall thickening in the deceased is indicative of a respiratory obstruction leading to asphyxia. Microscopic examination revealed significant inflammation and cellular infiltration within the larynx, consistent with acute allergic reaction or anaphylaxis. The degree of tracheal wall thickening suggests prolonged mechanical pressure was applied, potentially from external compression or self-induced constriction. These findings are conclusive in establishing a cause of death due to respiratory compromise. The expert would opine that, while the exact precipitating factor is uncertain based on the evidence, the combination of laryngeal edema and tracheal wall thickening strongly supports an acute respiratory event leading to fatal asphyxia. Interpretive elements include identifying whether the obstruction was external or internal in origin, necessitating further examination of surrounding circumstances and forensic context for a definitive conclusion. Chapter Resolution. The final determination of asphyxia due to laryngeal edema is substantiated by comprehensive forensic analysis, including macroscopic and microscopic examination of tracheal wall thickening. Evidence demonstrated an obstructive pattern consistent with swelling-induced airway compromise. Initial assessment suggested a possible external cause for the deceased's respiratory distress. However, subsequent identification of marked mucosal inflammation and tissue congestion shifted focus towards intrinsic mechanisms such as allergic reaction or infection. Evidence demonstrated an obstructive pattern consistent with swelling-induced airway compromise. Histopathological evaluation revealed cellular infiltration indicative of acute inflammatory response, corroborating edematous laryngeal changes that precipitated fatal airway obstruction. Key findings included thickened tracheal walls with compromised integrity, further supported by adjacent lymph node enlargement suggestive of systemic involvement. Microscopic analysis confirmed the presence of granulation tissue and evidence of capillary dilation consistent with hypoxic injury secondary to prolonged hypoxia. These observations collectively indicated that the primary cause of death was acute laryngeal edema leading to fatal asphyxia, thus resolving initial uncertainties regarding external trauma or mechanical obstruction as contributing factors. This case underscores the critical importance of meticulous pathological examination in distinguishing between various causes of asphyxia. The presence and degree of tracheal wall thickening indicative of laryngeal edema must be carefully documented, contributing to a comprehensive understanding of death mechanisms. The file remains open.